at about the 25-year mark from the earliest valve-sparing operation. So almost a quarter of a century of follow-up now. And I'm going to report to you here the longest reported series, which are the operations done by Tyrone David. And it's reported here out to 20 years. One of the important things that he noticed in his series was that the patient's survival was very, very close to the normal population of Canada. So these were operations that if you could do them safely, you could give patients survival, which was almost as good as a normal patient. He also showed that overall in his series, that remodeling and reimplantation operations had about the same freedom from regurgitation out to 20 years, though reimplantation was slightly better. But if you looked at freedom from reoperation, which was usually for regurgitation, the reimplantation operations were definitely better, with more than 90% of his series free from reoperation at 20 years, which is really quite remarkable. The only operation that gives this, I should say, the only two operations that give better results are the Ross procedure and replacement of the valve with a mechanical valve. But many of our patients don't want to take anticoagulants. And comparing the Ross to the Tyrone David series is not a useful comparison, because the Ross is performed for aortic valve disease, and the David procedure is for aneurysm disease most of the time. So it's not really a meaningful comparison. Those results are the best. They're the best in the world for valve sparing out to 20 years. What is the real world, though? Now, the Marfan Foundation in the United States has been very interested in figuring out which is the best operation for Marfan syndrome. And they are supporting a study of non-randomized patients. This is not a prospective randomized trial. But over 300 patients at 19 centers have undergone either a valve-sparing route or a Bentall-type composite graft to compare the results, again, in the real world. There was one death in each group, and one valve-sparing patient needed an aortic valve replacement. But there were no differences in the early morbidity. And so far, the reoperation rate has been very low with the valve sparing. So this tells us that valve sparing can be done at many different centers with very good results. But the most alarming part of this right now is that almost 10% of these patients have 2+ regurgitation. And this is only at about 3 years. So this is a bit worrisome, and it suggests that, as I think all of us know, that this is an operation that is very operator dependent. There are experts who have great results, but there are some good surgeons who have trouble making this operation work. Let me show you a few slides from our series at Johns Hopkins, which I believe is still the largest series in the world of valve-sparing root replacement for Marfan syndrome in particular. These are challenging patients because they are young and they have a severe connective tissue disorder. And because they're young, we need them to live a long time. We need to have operations that last a long time. But in this series, the survival was actually better with valve-sparing operations out beyond 15 years. The other patients were patients who had mechanical valves, and they didn't have bad survival because of the mechanical valves. The reason was because that if a patient presented with an acute dissection over the course of this nearly 20-year series, they were more likely to have a Bentall. So it wasn't the operation, it was the fact that the dissection group, by and large, had mechanical valves, and we know they don't have the same survival. We compared our reimplantation with remodeling operations, and again, the reimplantation actually had the best freedom from reoperation, even better than a Bentall, and both of those were definitely better than remodeling. Although the remodeling, more than 80% actually still had good results. So it's not that the remodeling will fail all the time, it's that the reimplantation is just a better operation for patients with connective tissue disorders, and particularly the young. And where the valve sparing was particularly better was in freedom from thromboembolic events. As we would expect with a natural valve, thromboembolism was extremely rare, but it was still a problem in almost 25% of the patients who had mechanical valves. Hemorrhagic events, again, almost complete freedom from bleeding problems in the valve sparing because, of course, they were not anticoagulated. Freedom from endocarditis was almost 100% out beyond 15 years. So we have an operation, the valve sparing, which has lower thromboembolism, lower hemorrhagic rates, and much lower rates of endocarditis. And I think we're seeing also too that the freedom from reoperation is low, but actually it's about the same as with the Bentall. So when you compare the Bentall to the valve sparing's less bleeding, less thromboembolism, less endocarditis, and at least in our series, a relatively low but similar risk of reoperation compared to the Bentall. Now let me focus on a couple of questions that always come up when we talk about valve sparing and who should have it, who shouldn't, and what are the limitations. One of the frequent questions I get is, what about a child who needs a valve sparing root replacement? It's usually a Loeys-Dietz or a Marfan patient. Will the patient outgrow the operation? Because if you do a reimplantation and the valve now sits inside the Dacron graft completely, the valve cannot grow. So whatever size the valve is when they have that operation, that's the size it will be for the rest of their lives. This just shows the distribution of graft diameters for all of our pediatric patients, and you can see that the majority had a 24 millimeter graft or larger. And I would submit to you that a patient with a 24 millimeter graft probably has a 21 or 22 millimeter valve, which is large enough to take them through and into adulthood. So most of these patients who have valve sparing operations as children have a very dilated annulus and a big valve to start with. And I think it's very unlikely they will need another operation for outliving their own valve. And this is an important point. If you need to do this operation in a young patient, if the annulus is already 22, 23, 24 millimeters, it's adult size valve. They will not outgrow that operation. Another question that comes up is the issue of trying to save the valve in the setting of an acute type A dissection. Now, this operation, as many of you know, has really been brought forward by the group in Hanover, Germany, which learned this technique in the early 1990s from Dr. David, and then because of the large number of acute aortic dissections, type A, that they saw, they applied it and showed that this was a very good operation, even in the setting of a type A dissection. All of you know that the dissection, a type A, stops at the aortic annulus. So you should theoretically still be able to do a reimplantation type operation, sewing the annulus to the inside of the graft. The early experience with this before 2006, 2007 was good. The mortality was a little bit higher, but remember, real-world mortality for a type A dissection in Europe and the United States is still somewhere around 25%. So they were careful to operate on good risk dissection patients. I still don't think the valve sparing is the right operation in a patient with malperfusion or in shock. There are several series that support this. One of the largest now is from Leipzig in Germany, and the point of their recent report was to show that doing a valve sparing does not add risk to an operation for an acute type A dissection. And in fact, the Yakubs and the Davids had an operative mortality of 15 or 16%, almost half of what the Bentall was. But again, this is not because of the operation, this is because of patient selection. Most of their very, very sick patients got a Bentall because it's quicker and in some respects more reliable. This just shows again from the Leipzig group that the survival was better with the David procedure patients, but remember, it's because the Bentals had sicker patients, more malperfusion. But if one looked at freedom from reoperation on the root, the Bental is still the best operation you can do if the main objective is to do only one operation. Now, Edward Chen, whose video I showed you before, has the largest experience in the United States with valve-sparing root in acute dissection, and he has had excellent results with this. An operative mortality of 5%, again showing these are carefully selected patients, but his results, when followed up, show that the durability of his valve repair was excellent. Almost 95% had freedom from 2+ aortic regurgitation or worse. He's had no patient where he's had to go back and replace the valve, and no patient who's needed a reoperation on the root. 20% of the patients needed some kind of distal aortic reintervention, often a descending thoracic or an arch replacement, but the excellent survival at 9 years. So this is an operation that if you choose the patient carefully and choose a patient who is, I hate to say a stable type A dissection because no type A dissection is stable, but the less sick type A dissections, this is still an operation that can work well. Let me talk about this, this trend now of remodeling operations with annular stabilization. These are operations that are done because the surgeons believe that a remodeling creates a better environment for the root for the leaflets in the long term. I don't think we know that this is true. But the Lansac ring is an externally applied ring that is put on often after or just before the Yakub type operation. So you have sinuses that look very good. You have subcommissural triangles, which are tissue and have more compliance to them. And then you can actually adjust the band or choose one after you've done the root reconstruction. And I think it's unclear whether this is actually better than a reimplantation. I can tell you that of the surgeons who are experienced in both remodeling and reimplantation operations, most of them stick with the reimplantation, because the reimplantation, once you learn it, is far more, I think, reproducible, less bleeding, and actually ends up taking less time. Dr. Schaefer's also from Germany. Lansac is from Paris, Schaefer's from Germany. Also believes that a single stitch, a heavy Gore-Tex suture around the base can achieve the annular stabilization, and he has good results with this technique. I'm a little worried about the suture and the fact that it can migrate some, that it might even erode through the aortic root. Again, I like the idea of a graft which can completely support the aortic root and is very reproducible. But there's a lot of interest in people who want to do remodelings and then stabilize the annulus. This is the David III concept revisited with new technology. And then finally, I want to mention two operations which are not root replacements, but root reinforcements. The sinus tissue is not excised, but the root is externally stabilized to prevent dilatation and dissection. The Florida sleeve operation, which is done on cardiopulmonary bypass with the heart arrested and the aorta transected, takes a graft, often a Valsalva graft, and slides it around the aortic root. Excuse me. There are small keyholes made for the coronary arteries, and this is secured at a level below the aortic annulus. And then, at the top end, a suture line includes the top of the sinus tissue, the external graft, and often another graft to extend and replace the ascending aorta. This has worked very, very well in the hands at the University of Florida surgeons and in many surgeons in the state of Florida. But there are some tricky parts to it. This coronary keyhole needs to be just right. If it's too small, it will compromise the coronary. If it's too big, you'll get a button aneurysm. And getting that just right is sometimes difficult. Many of you may have also heard about the PAIRS operation from London. Dr. John Pepper and Dr. Tom Treasure have developed this. The idea is the same, a mesh that fits on the outside of the aorta, although theirs actually goes up to the proximal arch. And this is a graft that is custom designed for the individual patient based on the CT scan of the aorta before. Because it requires planning, this cannot be done with a patient with an acute dissection. Obviously, that patient also needs aorta replaced. But this can only be done in elective settings. But they have now 160 patients with more than 100 years of follow-up, most done without using cardiopulmonary bypass, some using a small upper incision. And this, like the Florida sleeve, involves cutting keyholes for the coronaries and making sure that the graft comes all the way down to a level below the annulus. They have had only one patient die perioperatively, and it was because of compromise of the left coronary artery. So it still requires a lot of attention to getting the coronary arteries just right, but it is less invasive. They are doing these operations at a much earlier stage. Most of their patients have a root less than 4.5 centimeters, so they could be criticized as doing the operations too early in patients maybe who wouldn't even need an operation. But they have to do it at the smaller size to be able to get this graft around the base of the root without using cardiopulmonary bypass. If you are interested in this, you should look at a YouTube video called How I Fixed My Own Heart, because the patient, I should say the very first patient to have this operation, was an engineer named Tal Goldsworthy who had Marfan syndrome. He had a dilated root and was told he needed a root replacement, and after they described to him what that would involve with a sternotomy and cardiopulmonary bypass, he said, "I don't want this, I'm going to design a better operation." And it was he who developed the concept of a preoperative CT scan, a custom designed wrap, and then an operation that would be done less invasively. So he had the courage to design a new operation and be the first patient himself for this. And he is more than 10 years out and so far doing well. So in summary, I hope I have made the point that valve-sparing aortic root